Hey guys, I am Dr. Austin Conn with the Function First Podcast, episode 1. We are here with Dr. Ted Dower. He is one of my really close friends from grad school. We both went to Life University in Georgia together, and he is the head doc over at Dower Chiropractic. How's it going, Ted?
It's going well, man. I'm excited to be on here with you.
We were both saying a minute ago, it's kind of funny getting on this because we're good buddies. So we're getting into some professional talk here. We'll be throwing in some bros and dudes throughout this probably, but
Yes.
we'll keep it a little bit professional.
Yeah. Not exactly
Um,
like the talks around the fire pit with a cigar, but we'll try to
that's
keep it,
that's right. We'll dial it down a little bit here.
yeah,
We'll dial it down.
for sure.
But Ted, tell me a little bit about what got you into chiropractic in the first place.
Well, my joke on this topic is that I think I'm a chiropractor because my wife wanted to be married to one. But honestly, I was just obsessed with like human health and performance. I couldn't really shake it, and I went to school and got my undergraduate degree in exercise science. And even though I realized I didn't want to be a personal trainer forever, and I didn't want to work in a gym forever. I kind of got out of it and went into IT. But even while I was working in IT, I was spending my spare time thinking about exercise programs and kettlebell movements and healthy eating and nutrition and all these things, and like that's just where my mind was at. And so I remember I went to my wife after being in IT for a little while, and I was like, babe, we got to think of something else that I can do with my life, because I'm just not passionate about this information technology thing. And that's when we started brainstorming and figuring out what I could do. And she had worked for a chiropractor in high school and, told me about what he did. And I even went and met him. And I was just like, man, I just really think I could be passionate about this and give my whole mind, my whole heart, like to this type of profession over the course of my life. And so that's what motivated me ultimately to go back to chiropractic college.
That's awesome, man. We have the wife thing in common. we kind of joke too that when I met my wife, I had no idea this was the case, and I wasn't even in chiropractic college yet. But I guess years before that, she had had a chiropractor get rid of some migraine issues that she had been having. And her mom would joke, and she's like, "You're constantly going into the chiropractor. You're going to have to marry one day with the amount of visits you're taking in." And so it's just funny how things work out that way.
Yeah.
Um, on a similar note, on my end, well, I guess this is not so similar, but my dad was a chiropractor growing up. So I got to see all the benefits of that had, first of all, in my life, where I barely had any injuries through college and athletics even. So anything that I had go on, I'd feel that little twinge, some minor level of pain, and he'd get right on top of it, make sure that we were feeling good, ready to go to the next practice, the next game. Um, so that was just hugely beneficial to me on my end. Then on top of that, and I think you saw a part of this through grad school, we got more into the working out side of things, the rehab side of things. And I'm going, oh my goodness, I feel even better than I did before, So starting to compile, hey, maybe what if we pair some of this rehab with some of this chiropractic that's got me along this far? And it's really just been an awesome marriage in my practice, having the chiropractic adjustments, the soft tissue work, and the rehab exercises all pair together and work with
Yeah,
one
man. And
another.
to that point, like I didn't have the benefit of my dad being a chiropractor. So like you and I both played college basketball. Like when I was playing basketball, like I had terrible knee pain. I remember I tore my labrum in my shoulder. I did lots of different things, and I didn't have that perspective in my life. I had the orthopedic doctors and the surgeons looking at it. And so I really feel like I was you know, John Stockton always talks about the reason he had a 20-year career was, and he would give 100% of the credit to the chiropractor. And I really feel like if I'd had a chiropractor or somebody with more of a conservative lens towards my healing at that, during that season of my life, it would have helped me a ton. So I'm envious of that for you, but it's something that makes me even more fired up and passionate about chiropractic going forward, knowing that I probably did have some surgeries I maybe didn't need, or, would have maybe been better served by some conservative management and care. Like it fires me up to get out into the community and try to reach people with this message.
That was kind of the funny thing on my end too, is the first time I didn't have a chiropractor was college basketball. And I remember I woke up one morning and had torticollis through my neck, couldn't move, got out of bed. I'm like, what do I do? Oh no. And went to the team trainer and he's like, I don't know, good luck. I'm like, shoot. He's
Yeah.
like, you taking any Advil? I'm like, sure. Yeah, we took some Advil, still felt no better. Eventually, I was like that for like 3 days, and ended up going to a sports chiro, which you would think I would have known better at that point, but it shows you how stubborn we can be as guys sometimes
Yeah,
too.
no doubt. Yeah.
Eventually made it to a chiropractor, and the next day felt like $1 million, and I'm like, okay, we're on the right path with this education and what we're getting into, and it was just that reassurance that I needed too, that we're going to the right profession.
Yeah, no doubt.
So, tell me a little bit about what the most common issues are at your office that you treat. What do you
Mhm.
see most often, would you say?
Yeah, we've had it's funny, I feel like we've talked about this before, but like you find that like one case where it's successful and somebody gets better and then they tell a friend and like the thread that's kind of unraveled for me as far as that goes is cervicogenic headaches. I've just had a lot of, I don't want to call it good luck because I think that we do have a good education and we know exactly what we're doing, but like I've just had a lot of success with cervicogenic headaches and it's led to me seeing a lot more of those cases. Word's gotten out. And so I end up taking care of a lot of people with headaches, headache type symptoms with, and for me, it feels so simple what I do. But it is something that's hard to do for yourself. And so had a lot of success with that for me personally.
That's awesome, man. That's awesome. Were there any other differential diagnoses that you think kind of kicked in with that,
Mm.
where you're going, okay, it could be a neck issue, it could be something else, and then how'd you manage that?
Yeah, absolutely. Well, I think that what you find when you get into that is that there is like little different triggers for everybody. And so what I find I'm doing most of the time, as far as like reducing them and keeping them from coming back, the education component is huge. And so figuring
Yeah.
out like, hey, this is what's going on. Like you have this headache with it, it's coming around up behind your eyes, all of this. But figuring out, okay, yours is like at the very base of your skull. And it seems like, we can relate it to maybe looking down at your phone or doing something like that. Or like, okay, your trigger is like when you're in the car, all of that. Like that education component and piece is really what I find as far as like communicating with the patient and figuring out what is it that's like related to this, what causes it, and then we can really go after that as far as helping them understand like but as far as people are always trying to figure out with headaches like is it something I'm eating, is it the light, is it the and so I think figuring out what are the mechanisms, what are the things that are causing your headaches is huge as far as like honing in on that diagnosis. But I mean usually when somebody comes in with headaches and it's got the kind of those common characteristics, the differential, sometimes I know, just in the way that they're describing it, there's not a lot of missing as far as the diagnosis goes. So,
I think that's one thing that is so underrated with our profession is how well chiropractors are trained in the history and diagnosis of cases. So many of our courses, and Ted knows this, I'm more so speaking to you if you're listening. So many of our courses are based on can you identify the multiple different things that pain could be generated from? Do the orthopedic or neurological exams to make sure that you figure out exactly what that's stemming from, and then be able to provide the proper treatment for that. So I'll tell a lot of my patients right away, your first visit is the most important visit that you're going to have in this office because if we're treating the wrong thing with the wrong methods, you're not going to get better. Uh, so kind of my example, the most common thing that I've seen recently, and it's been weird. It seems like it rains, it pours sometimes because it always changes. Early on, I had a ton of shoulders, then it was a ton of low backs. Lately, we've had a ton of sciatic pain where people are having this radiating numbness, tingling into their leg, just consistent pain over time. And this has happened legit 3 times in the last month, which has kind of thrown me off. But it's cool that we're able to recognize this, where they'll have MRIs of a disc bulge in their low back, and they've had the shots in their low back to try and dissipate the pain. They've gone to basic PT trying to get rid of it, things like that, and they can't get rid of the pain. So they'll come in and everything on imaging and everything on paper says, yeah, it should be, a disc issue. Well, we'll do some orthopedic neurological exams in person, actually put our hands on the person. And I'll start to realize, hey, it's not a disc. Like all of our disc orthopedic tests are negative. And it's like, okay, just because it's on the imaging doesn't mean that's the issue. So then we'll start getting into their piriformis muscle. And one guy, and I've told this story to a lot of patients, one guy had a golf ball sized knot in that piriformis. And he came in with a walker when he came in his first visit. Again, they'd treat his low back over and over and over again. I told him, you're really going to hate me. So we started doing Graston technique or scraping. So again, if you're a patient of mine, it stinks. It's tough to go through when it's a really significant adhesion like that. I dug in, broke it up, and he called me the next day and he goes, "Doc, what'd you do to me?" And I'm thinking, "Oh no, what did I do?" You know? Um, but he goes, I'm out of pain. I've been hurting for like 3 years. We're good." And that was the coolest version of this. Oftentimes it does take a lot more than one visit. But
Mhm.
um, being able to break up that tissue and get that proper diagnosis that, hey, that nerve's getting impinged by your piriformis muscle, not that low back disc. What a big difference that makes. Um, Kind of banking off of that story, I know we've had these conversations before about the reliability of the imaging. Do you want to talk about that a little bit? I'll kind of dish it over to you.
Oh, 100%. Well, and I think that, one of the things that your story even provokes in me, I have been kind of shocked somewhat after being inside of healthcare for the last 4 years. I just assumed that everybody was doing their due diligence in a thorough exam. You know what I mean? I just assumed that. And I'd have people come in with imaging findings and diagnostic findings and, previous things from previous. And at first, my presumption was, well, they did everything right and this is correct. And, I'm never going to try to poo poo on anybody else. So I'm certainly not naming any names here, but like I, I have been so shocked at the amount of times that somebody comes in with a diagnosis that the second I put my hands on them and start doing some orthopedic tests and different things like that, like I'm like, I don't know how they ended up here. And so it is so important, like get your hands on somebody. And I'll even ask the patient sometime, has anybody touched you? In this whole process, and they'll have had imaging done and they'll have seen doctors and they'll have given their history, but nobody will have touched them yet. And that's one thing that you'll never see with physicians like us. And so, but to your point, like imaging is such a low part of what I do, because like the clinical findings that you see inside the clinic, like both corroborating them to what you're talking to the patient about and what you actually see and what the patient, like I love the name of your business, because function first, like that's what we're looking for. So what are the things that are actually inhibited? What function don't we have? You can't tell that from a picture. And an x-ray
Mhm.
is just like a slice in time. I tell people all the time, sometimes an x-ray comes back and people are like, oh my gosh, that curve in my back. First of all, the patient, it would be so easy for us to scare our patients with their x-rays because they don't know that like they have primary and secondary curves that are totally normal to them. I could scare every single patient I have with that curve's not enough or that curve's too little. First of all, everybody's different. They're on a morphological scale here. And so we don't really know if their imaging is abnormal, if it's completely normal for them. And so what I always tell people is like, okay, we've taken an x-ray. We have a picture in front of us, but just like you don't love every single picture of you on your camera roll on your phone. Sometimes you take a bad picture with an x-ray. And
Mhm.
so there's really no telling here. The other thing that I tell patients is even with MRIs, like I'll know for a fact like that there's a disc something or other going on with my patient. Sometimes the MRI result will be like, oh, it's just a minor bulge and there's no pressure on the nerve root. And I'm like, look, I understand that that's your imaging finding, but the structures in your back are dynamic. And just because you were laying comfortably in a tube and there wasn't pressure on a nerve root by a disc in the tube doesn't mean that there's never pressure on a nerve root by a disc. And sometimes you see annular fissuring on the imaging, stuff like that. Like there's every sign and indication that there's probably a disc that's herniating and going back and herniating and going back. So there's other things that we can see on the imaging that so anyways, to get back to your original point, which you originally asked me, let me say it a little bit more pithy here. Your imaging does not say enough about you for us to make our whole clinical rapport be built around it. Like we need to be looking at you as a person, checking on what you can do, what you're capable of, and that's what we should really be making our clinical decisions based on. There's like the population studies are so fascinating, but one of my favorite studies basically showed that like if you took, I think it was 100 college volleyball players, they put them in an MRI too, all of them 100% pain free, and like over 50% had disc bulges and several had disc herniations with zero pain, zero symptoms. So I'm not going to base all of my clinical decision making off an image. I don't think it's wise for you. And quite frankly, I think a lot of practitioners do it as a form of fear mongering. And so I just refuse to participate in that. I know that you have similar convictions. So,
Absolutely. That is one of the things that really bums me out a ton too, is when you base the whole diagnosis off of the imaging and you're not bringing in some of that testing as well to see what else is going on with each individual patient, they start to view themselves as a condition at times as well. So people will come in ahead of times and be like, "Oh yeah, I'm a herniated disc. I'm going to be a really hard time. You're not going to be able to get me better." And it's like, "No, not at all. We can 100% get through a herniated disc, first of all. Second of all, if I took an MRI of everyone in this gym right now, 50% of them would have disc herniations, and they're out there working out, and you're in here in pain. So that doesn't mean that you can't get to their point where, hey, even if that's still on the imaging, you're out of pain, you're feeling better. Um, so that's something where even just having that positive speak with the patient goes a long way.
Yeah.
Having that attitude towards healing and getting better, it's going to motivate them to do their exercises. It's going to get them coming in more consistently in the office. And I might be giving away tricks of the trade here too, where we just want to make sure that we're working alongside our patients and encouraging them in that path of getting better. The fear mongering and the strict diagnosis is never a great idea, especially because if somebody comes in, like I said, and they do have a finding on imaging, that doesn't mean they might not have a couple other things going on, which from the outside sounds bad. But the good side of that is we can work on those couple other things and have a little bit of a more nuanced approach. Um, for example, we'll go out to the gym. We'll be working on the low back, and they're like, "Oh my gosh, I can't even get through this exercise because my hip flexor is grabbing so hard every time I try to do it." So what we're gonna do? We're gonna do a hip flexor exercise and come back to it. We're not gonna let you hurt and just struggle through the exercise the whole time. So being able to get into some of even those secondary conditions at times first, so that we can get to that primary from a healthy angle and a healthy perspective, what a huge difference that makes. It's such a benefit for the patient.
Yeah.
Speaking towards your studies as well, I was a fellow friend that we have, Ben Pepin. Uh, I was just talking to him recently about a study in, I believe it was athletes over the age of 40, and it was 98% of them had some level of shoulder pathology. So again, if you're over 40 and you go to get a shoulder MRI, it's going to be positive.
Yes.
That
Dude,
that doesn't mean you
100%.
need surgery. That doesn't mean that you're gonna run into these cascade of issues over time. We can make sure that we're basing those shoulder biomechanics um, from a healthy movement pattern, a healthy movement perspective, so that, again, and I'm going to get into a little bit of a rant here, make sure that we're stabilizing that shoulder blade, because that seems to be the most common issue that I see in shoulders is they start to round forward and wing, and we lose that stabilization standpoint, and that whole rotator cuff locks up. So usually my goal is, can we mobilize the rotator cuff, stabilize those scaps, make sure that they're controlled through the range of motion, and usually we're able to centralize this humeral head more so in the socket, and they're out of that labrum pain. So even patients that have a tear, it doesn't mean you have to live in pain. And that's one thing that I think as conservative practitioners, we really want to make sure we're getting out to our patients that, hey, you're going to be okay.
Yeah.
let's try this conservative things first.
Yeah.
You don't need to get cut open first thing. Let's try something a little bit more simplistic. See if we can help. And I think we're both realistic too. If it's a case where we're not seeing improvement or we're not seeing that help, we're gonna admit it. Hey, you just might be a candidate for this, and that's okay. Granted, I think a large majority of patients get better.
Well, and you and I see this all the time in our clinical practice, I'm sure. And I also, like, I coach fitness classes some, and I see this all the time there as well. Somebody develops a belief about their shoulder, rotator cuff pathology, which I don't know. Like, everybody that I've ever known that's gotten an MRI of their shoulder has rotator cuff pathology per I don't know what it takes to have that. I can't remember what the exact guideline is, but everybody's got it. And so some people come in and they say, well, I can't do that. I have a rotator cuff problem. But what that leads to is I'm not going to do that movement. And then all of a sudden my shoulder hurts worse. I'm not, I'm going to stabilize it so it doesn't keep hurting. And then it just leads to this pathological cycle that they never break out of. And so that's why the work that you and I do is so important, is because, look, somebody needs to handhold and like help the patient. And I don't mean to sound like I'm babying, but like we need to help them find what are the painful, like the pain-free things that you can do with your shoulder. And let's just start there. Let's see let's explore what the shoulder can do. And as we discover what the shoulder can do, you're going to build confidence through a fuller range of motion. And then it's like, okay, maybe I will do that. Because there's been times where I've had debilitating shoulder pain, and I'll tell like an embarrassing story about myself because I know better, but I still made the same mistake. I the program I was doing for my strength training had me doing closed grip bench press. And it said to do a certain percentage of my max bench press. And I put that on and, oh, I've got pain in my shoulder. And I'm like freaking out. I'm like, oh, is my form bad? Like, what's going on? And I'm like, oh, I can't get it to not hurt my shoulder. I'm freaking out. I'm freaking out. And then all of a sudden I have a moment of clarity. I calm down. Okay, let me just move my hands through that range of motion without any weight at all, pain free. Okay, let me just take all the weight off the bar. Okay, I can do it with 45 pounds, pain free. Great. All right, then I just figure out what I can do and I introduce that movement there. And then we can build up the strength to that. But I just didn't do a bunch of closed grip bench press. So jumping in at the weight that he wanted me to jump in at wasn't going to work for me. That's where the skilled practitioner can meet their patient and figure out, okay, this is what's going on. You're scared for these reasons, and I get that. Let's reduce, let's draw back, and let's figure out a good plan to proceed forward, as opposed to like, okay, I'm just shutting it down entirely, which is, you and I both know in healthcare, that's the common line. Oh, running hurts, stop running. Pat myself on the back, I've done a good job. No, you haven't. You have not helped that patient. And so, yeah, I mean, this is where I think the work that we do is so important, and why our message needs to reach the world is because people want to do things that they are passionate about. And we need to be the kinds of practitioners who help enable that, as opposed to the kinds of practitioners who scare them away from it forever.
I can't tell you how many times I've had CrossFitters come in and go, yeah, my doctor told me I'm not, I shouldn't do CrossFit. He goes, well, here I am at the CrossFit gym. Like, obviously, I'm going to keep going. If you love something, you're going to keep going through it. There's not a lot of things that are going to hold you back from that. So I am the last doctor on the planet that's ever going to tell somebody, hey, don't do what you love. I'm going to recognize that you're going to do it anyway. So how can we do that safely and uh, effectively through movement? So typically in our office, what we'll start with is building up range of motion, similar to what you were saying. And that's one of the nicest things about having our hands-on approach is we're able to do muscle work. We're able to do adjustments. And usually people get off that table and they're like, oh my goodness, my shoulder moves awesome. This is great. I'm back to it. Well, the problem is if they go back to their same old movement patterns that they were having previous to that, they're going to fall right back into that same pain pattern. So that's where it comes in such handy that you're educated as a personal trainer as well, and that I do the rehab chiropractic on my side, is that we're able to say, hey, do these 2 exercises at home or go over to the gym and make sure that now that we've got this new range of motion, let's build strength through it. Let's build some stability through this new range of motion. And with patients, if you can get a full range of motion back, build strength through that full range of motion, and then over time, increase load, increase speed. Hey, if you're getting into a full range of motion with load and speed, you're good. You don't
Yeah.
need me anymore. Come back in for check-ins. Just make sure that you're staying healthy and staying on that track. But that is the key to health in my mind, from an athletic standpoint, is full range of motion, strength through a full range of motion.
Oh, yeah. I mean, I think it's the fountain of youth too. I mean, so many people are talking about anti-aging, and I feel like I see the creams and the things. It's like, you want to age well, like move your body through a full range of motion and be able to do it with even more than your body weight. Like, you're going to age really gracefully. You're going to be the envy of the other people, who are looking for quarters on the ground all bent over, you know what I mean? Like that, if you can move your body through a full range of motion and still play and explore and do the things that you want to do, I mean, that's what I would want from life. And that's what we're trying to give our patients out here.
But one of the most gratifying things to see is older patients that come in,
Yeah.
and we do a lot of our exercises on the ground. If you've come into the office, we almost always start with core stability. We want to work on building that strong core and intra-abdominal pressure, that core strength to make sure that you're able to get through movements correctly. And so often these older patients, they're like, I'm not getting on the ground. I'm like, we're going to get on the ground. I'll help you down. I'll help you up. We're going to be okay. And being able to build up that strength and that confidence. And then again, but by the end of our treatment plan, they're like, oh yeah, hop on the ground real quick, get up real quick. And it's like, what a difference that's going to make in the longevity of their life as well, that they're able to move, able to get through a full squat, able to, like I said, get up and down from the ground. Um, like you said, that's the epitome of health. That's the fountain of youth, where that's going to encourage them to have a longer, healthier life overall.
Yeah. Hmm.
All right, Ted. So what makes a good long-term solution?
Mm. This is a good question. And it's honestly something that in my own practice I've kind of had to grow in, because one of the criticisms of chiropractic just at large is that you have to keep on doing it, and or you have to keep on going and getting adjusted or whatever, which I suppose is like a fair criticism from the outside looking in. But I also don't know of any other healthcare practice that doesn't say you're gonna have to come back at some point. You know what I mean? So I think, as far as like what you mean by like long-term solution, I think that for some people it is a decent solution for them to, hey, I want to stay mobile, I want to stay feeling good, to go get a regular adjustment or to get a regular tune-up. Now, that's not the solution to living a vibrant, healthy life. That's a solution to enable you to live a vibrant and healthy life. So the only long-term solution is find something that you're passionate about, that motivates you to get out of bed, that you're excited about, that you want to pursue, and go pursue health in that way, because health is really expression. I I I guess what I'm trying to, health is not like, uh, my biomarkers are perfect. Health is not like, oh, my blood pressure is good. Health is like, can I do the things I want to do? And so, as long as you're able to do the things that you want to do, like the solution is like, I know what it takes, what the steps are, and I'm continuing to be able to do it. Insofar as like we as chiropractors can help people discover that, that's amazing. Usually people come into the office with that already in mind, like it's in their history, even though they don't know. Like they'll say things like, I want to be able to get on the floor with my grandkids, or I want to be able to run a marathon, or I want to be, so like, like as a practitioner, like this is what's firing them up and what they want. And then you can just get on their team and be a part of their team and helping them achieve that goal in whatever way that looks like. But as far as like, you know, long-term solution type, like based care, like I think that it's just, hey, what is it that you're trying to accomplish and how can I help you? There's not necessarily going to be like I say goodbye forever. Like the patient's going to probably need more things from you at some point if you're doing your job well and they trust you and want to confide in you. So, but I'd be interested, honestly, like, how do you answer that question?
Yeah, absolutely. So, but one of the big aspects that I'll talk about is something similar to what you said, is what's going to keep you moving.
Mm.
That's a big piece of it as well, especially as somebody who isn't super into one form of exercise. So I'll get the question a lot: should I run? Should I lift weights? What should I do? And it's like, what do you like? Like, what are you going to stick to? If you like lifting weights, do that. If you like playing basketball, if you like skiing, whatever, what's going to get you outside, active, moving your body? From a treatment perspective, typically to get through one specific injury, I want to make sure, similar to what we were just saying, we're getting through a full range of motion again. And usually that is with hands on care. So we're doing soft tissue work, we're doing adjustments, we're removing any adhesions, whether that's through a joint capsule or through muscle or myofascia, so that you're getting that full range of motion back. And again, if we don't now support that new movement with rehab and stability work, you're going to fall right into that same pattern over and over and over again. So once you get that newfound range of motion, we're going to work on rehab exercises that support that newfound range of motion. And every week with patients, I'm sending them home with new movements. So it's like, all right, let's make sure that we're progressing. You know what to do when you feel tightness in a specific area. Speaking to what you talked about earlier, making sure that they're educated on why they're doing the exercises, right? So it's not just a checklist, go home and do this. It's, hey, we're doing these pigeon stretches to get through your piriformis because that's clamping down on your sciatic nerve. If we're able to release that piriformis, you're going to move better. So here's this pigeon stretch to do over time so that this doesn't come back and clamp down on that sciatic nerve again. Now, is a one pigeon stretch going to fix it? No, right? So just building up different drills with hip mobility, making sure that these patients have the tools long term and these exercises long term to maintain good hip mobility. Uh, they're going to have better results long term. Like you said, people are going to have hiccups and bumps in the road. So hopefully, with the tools that we give them, they're able to apply those and make sure that they are much less likely to fall back into that large amount of pain that they come in to see us with. But sometimes you're right. Just pop back in, see how we can help you, right? Make sure that we're able to carry you across the finish line.
And I just want to have that kind of like rapport with my patients. You know what I mean? I want them to feel like they can come see me and ask me about whatever. presume it'll be something musculoskeletal, but like they can come in and see me, get a great soft tissue treatment, leave the clinic feeling great, and gain some information about what they have going on. I never want to be the kind of person who's like, okay, I fixed it. Don't come see me again. You know what I mean? Like,
Mhm.
I want them to like access is what I want. I want to help them, and I want them to feel like they've been helped when they come. So, and I'm not, and you and I are both this way. Like, we're not just trying to be like smash and dash chiropractors. Like, I don't want to just jump in the room with you, crunch your bones a few times, and then send you on your way. Like, I really aspire to like empower my patients to do the things that they want to do. And so the only way I can do that is if I know what they want to do. And so, yeah, I think, again, do I, do, I'm stronger with the criticism now of like, oh, like they have to come see you again. It's like, of course they have to come see me again, and I want them to come see me again. I want them to come to me when they have questions about their body. I don't necessarily want them going to another practitioner who, like we've said and like we've seen, sadly in our clinical practice, who's going to tell them, oh, you have to have a surgery on that, or oh, you have to do like, no, come see me. Like we can filter some of that stuff out. We can work it through, and we can figure out what a good long-term plan is with you. If the plan doesn't work, we'll figure out what we need to do next, or we'll get you to a different type of practitioner if that's the case. But yeah, like I really just, I want patients to feel comfortable with me, and I want them to always know that I have their best interests at heart. And I want them to always know that we're going to try to solve this problem together. And long-term, my goal for you is for you to be vibrant and healthy. If I'm a part of that, I would love it. So,
I love that, man. I love that.
yeah.
Well, one thing that kind of stuck out to me that you mentioned as well is just making sure that we build that plan with them. I think a lot of people have this misconception that I'm just going to come in and get popped real quick and I'll be good forever. And that's not the goal. We have to build up to getting those results that we want. It took a long time to get that way, typically. I've got bodybuilders that have had, crazy shoulder movement for 30 years of bodybuilding. I've got runners that have, again, told me, hey, I know I've had bad running form for the last 20 years. How are we going to fix it? And it takes a little bit of time at times. The nice thing is we can build that plan, like you said, of step by step, making sure that they're able to reach those goals over a period of time and have those realistic goals. That they know what they're getting into, they know the path towards getting pain free, and hopefully getting back to what they love.
Yeah.
Ted, any
Yeah.
final thoughts before I let you go here?
Man, and the thing I like about us on this topic is I feel like you and I both think the same way. We like to work on short time scales. Like we expect ourselves to succeed. And I feel like
Mhm.
sometimes, I've had people come in from other chiropractors and they'd be like, yeah, I went for 4 months and I just hadn't gotten the result. Like I see this with PT and with chiropractic all the time. And they'll be like, yeah, I went for 4 months, 3 times a week. And it's like, look, like, did they not re-exam? Did they not check on your progress? Like, and so really my expectation for myself is like, okay, in 2 weeks, this should be 50% better. And if it's not
100%.
50% better in 2 weeks, I'm not doing my job and we might need to go talk to somebody else. But like, that's my expectation for you. That's my plan in this. And if we're like, sometimes we're 100% better in less than 2 weeks, that's great. But like, this is my minimum. And if we're not here, like, let's make a different plan, either inside this office or elsewhere to figure out what we need to do. So anyways, I know that you
Yeah,
and I
you,
could
you
wax
nailed it,
eloquent
man.
about this. Yeah, for
You
sure.
nailed it.
Hmm.
Awesome, man. If you guys are in pain and you're in Alabama, Ted, tell them how to reach out to you, how to contact you, all that fun stuff.
205-989-4114. Hit us up. No, Dower Chiropractic. We're on like all the socials, and I think we have dowerchiropractic.com. So would love to see, yeah, if you're in Alabama and hearing this, come on through. Yeah.
I love it. I love it. We'll attach everything in the whatever captions or
Mm.
what do you call it? The
Show
caption.
notes.
There we go. My goodness. Yeah, the show notes. We're
We're
official over
fancy.
here. Podcast number 1, baby.
Let's go.
Um, Same deal over here. f1sportschiro.com, or just click on either one of our names on whatever platform this is and shoot us a message. And I'm sure we'll get back to you pretty darn quick. Ted, awesome talking to you, dude.
Can't wait to do it again, man.
Yeah, absolutely. We'll run this back for sure.
Yeah.
Hopefully with a little more experience under our belts here.